And the goal is to review illustrative cases of undiagnosed CHD presenting in adulthood. And all these patients presented to the general echo lab, so you will see these patients in the real world. So this is a 19-year-old male with elevated blood pressure. He was diagnosed with BAV at age 4, and he was having issues, echoes routinely every year, and then they all showed that the bicuspid valve was working well. Then at age 9, he was diagnosed with hypertension, and he was put on lisinopril. He was athletic, otherwise healthy, no other medical issues whatsoever. So here you can see his physical exam, so blood pressure 176/80 on the left, 160/82 on the right. His BMI is normal, he had normal carotid upstrokes. And upon auscultation, he had a systolic click in keeping with the bicuspid valve, but no other findings. So as usual, he gets a TTE, and you can see here his bicuspid valve, so a really nice looking bicuspid valve, fusion of the right and left, as we typically see. Then when we put color Doppler on, you can see that the valve works completely normal. Now we're going to move to the suprasternal notch view, and then the apical findings were completely normal, so normal structure and normal function. And this is what we see on the suprasternal view. Then at the end of the study, as we move to the abdominal pictures, this is what we see. So this is the abdominal aorta PW Doppler. So in light of this, what's the diagnosis? Congenital aortic stenosis, coarctation of the thoracic aorta, coarctation of the abdominal aorta, or this is artifact. We're just sampling a branch vessel. Please go ahead and vote. Very good. So most of you said coarctation of the thoracic aorta, the typical coarctation that we see, and you're absolutely right. And here you can see his CT had near interruption of the aorta, so very tight coarctation, as you can see with the arrow, but you also see these very angry collaterals as you try to bypass the obstruction. So this is undiagnosed coarctation that was very severe in a patient with bicuspid aortic valve. So after a very extensive discussion regarding stenting versus surgery, the patient decided to go for surgery, and here you can see the specimen on the left-hand side. You can see the isthmus there, but it's not when you look, until you look at the short X that you can see how tight the obstruction is. So you can see all this narrowing of the descending thoracic aorta, and the opening was actually pinpoint. So this is near interruption of the descending thoracic aorta. And here you can see what happened. So the patient received a graft, and on the right-hand side you can see the post-op CT. You can see this widely patent large graft, and there was no gradient between the leg and the arms anymore.
Will, do you mind going back to the echo for just a sec? There was a question about, was that really a bicuspid? So it would be, I think, nice just to go through the features once more. Sure.
So again, short axis view, and then this is one that, and sometimes this can be very challenging. So as you're scanning, I think for sonographers, it's important that you pan up and down so that you open all three commissures. And statistically speaking, the most common one will be fusion of the right and left, as you can see here, followed by fusion of the right and none. And then fusion of the left and none is very uncommon. And we joke that if you think that is left and none, you're wrong until proven otherwise. So, but I think, again, you can argue that this is the so-called partial fusion. Some people think that there's no such a thing. You're either bicuspid or tricuspid, but it can be very hard, and I think that's the thing. You just pan up and down, and if your parasternal view is not sufficient, you just go to the subcostal. So you just have to try to interrogate all three commissures from different windows. So now there's a different patient. He's actually in the medical field. There's a 28-year-old found to have coarctation in a CT done for cancer staging. And very similar stories, known to have a bicuspid valve with hypertension that was managed medically. And once again, you can see here the suprasternal notch view and very similar findings. Sometimes by 2D it can be really hard to find that narrowing of the descending aorta. And same thing with Doppler. As you put color Doppler on, it's very hard to see the aliasing because the opening is pinpoint, so you just have to keep that in mind. So that's why the CW is so important. Sometimes you even do the CW blindly, trying to find that pinhole. And when you have severe coarctation, you typically see what you see on the left, where you see this high velocity in systole, as you can see here, but also you get this very typical diastolic runoff, which is a sign of severe coarctation of the aorta. Now, the other question that comes up a lot is how to measure the gradient, whether you incorporate the diastolic runoff or not. And on the right-hand side, you can see the way of measuring it. So you just incorporate the systolic part of it, because if you take the diastolic component, you will falsely decrease the gradient. So as we did here, we just measured the systolic component, and you can see here that the gradient was quite high, so a mean gradient of 41. And typically we would say that there's significant coarctation if the mean gradient is more than 20. So it's been shown that the mean gradient for coarctation correlates better with the peak-to-peak gradient in the cath lab. So mean gradient correlates better with peak-to-peak measured invasively.
And then can you just tell us the T wave that you include there?
Yeah, typically the end of the T wave. So again, hypertensive patient with very severe coarctation by echo, what should we do? Medical therapy, coarctation stenting, or surgical repair. So stenting as the first option, followed by surgical repair. I'm glad that none of you chose medical therapy. And I think that's important. I mean, I'm glad that there was kind of this split, and we'll talk about it a little bit more at the end. At the end, we actually decided to proceed with coarctation stenting. The patient saw a surgeon, saw an interventional cardiologist, and I think a lot of the decision was based on the fact that he was just recovering from cancer and had a recent operation, so we decided to go with stenting, and there's pros and cons in both approaches, and we can talk a little bit about that as we wrap up. And here you can see the images. So the patient was taken to the cath lab. On the left-hand side, you can see this obvious narrowing here with this shelf-like obstruction that you can see on the lateral camera as well. So a very tight coarctation of the aorta. And as I mentioned, the patient underwent stenting, and on the right-hand side, you can see the final result. So wide open descending aorta with a gradient of 0. And the other thing you can see is, if you wait long enough, you can see these very large IMAs that were bypassing the area of obstruction. So again, this is another typical finding when you have severe coarctation of the aorta, these large collaterals bypassing the level of obstruction. So I just saw him a year after follow-up at the intervention. He was completely symptomatic. In fact, he was off BP meds because on therapy he became profoundly orthostatic. So he was doing great, and there was no residual blood pressure gradient at the bedside. Now let's talk a little bit about the echo-Doppler diagnosis. So as we talked about, it's important to interrogate the descending aorta by 2D, but sometimes you can miss that because the narrowing is so severe that you're not able to see it. So it's important that you use your CW Doppler and you just sweep around, and sometimes the peed-off is actually better than the guided one because you're trying to catch that pinhole narrowing. But it's also critical that we interrogate the abdominal aorta by PW, and here's what you expect to find in severe coarctation. There's reduced systolic forward flow velocity. There's absence of the diastolic reversal that happens in early diastole shortly. And when you combine the two, you have the typical sawtooth pattern with this diastolic runoff. And this is what we're talking about. You can see on the lower panel, this is the example from the first patient, so this typical sawtooth pattern. And then in contrast, when we look at the normal, you can see that there's very brisk upstroke with a complete normal max velocity. And then in early diastole, you have this reversal, and then you have forward flow again. This is the so-called triphasic pattern, so forward flow that is very steep, then the reversal, and then forward flow again. Sometimes this component might be missing, and this is the so-called biphasic, which is also normal. So steep upstroke, normal velocity with early diastolic reversal, that's a sign of normal findings. Now, the question that comes up a lot is whether you have coarctation when you're sampling a side branch, and I think the key thing is to pay attention to the upstroke. And you can see here that the upstroke is very steep. You might have this diastolic in a smaller branch because of resistance, but the key for the diagnosis of a side branch is actually the upstroke, where it's steep versus very slurred in someone with coarctation. So don't be fooled by this diastolic runoff if the systolic component is normal. And we always talk about the sawtooth pattern, but why does it happen? And I think this is the example from the second patient. You can see the diastolic aorta is in blue, the ascending aorta is in red, and when we look at the descending aorta contour, the upstroke is very slurred, and that gets translated into the slurred upstroke of the PW. And then when you look at the pressure difference between the ascending and descending aortas, you can see that there's a gradient diastole, and that's what caused that diastolic runoff. So this is the reason for this sawtooth pattern that we see by Doppler. And here you can see her post-stent data, so the descending and the ascending aorta traces now overlap. There's no gradient whatsoever. And when we post his abdominal aorta during follow-up, you can see that that early diastolic reversal is now present, so complete normal flow, no residual coarctation. Now, just a summary in terms of coarctation of the aorta is a common, uncommon cause of hypertension, so think about it in patients presenting with de novo hypertension. So whenever you have someone with a new diagnosis of hypertension, don't forget to palpate the femoral pulses and also check the blood pressure in the legs at least once to ensure that you're not missing the diagnosis. Now, why is it important to diagnose coarctation? Is because if you do not diagnose or repair, that leads to decreased survival. So unrepaired coarctation is associated with increased mortality. And the other thing to remember are the common associations. So bicuspid valve is present in 50% of patients, brain aneurysm in 10%. This is actually work of Dr. Connolly. And also think about Turner syndrome because that's very common in patients with Turner. So look for the other features. So webbed neck, low hair in the line, so on and so forth. So just remember that it can also be syndromic. Now, if you had a patient that has had a coarctation repair, either surgical or stent, just keep in mind that some things are common in follow-up, so hypertension is very prevalent, even if there's no residual obstruction, so that happens in 80% of patients. Don't forget to exclude recoarctation. That can happen in 30% of patients, especially in those that had neonatal repair. Now, just interrogate the aortic valve if the bicuspid aortic valve is there, and also ensure that you're doing aggressive management of CV risk factors because those patients they have higher risk for stroke and MI.